What's up, future respiratory therapists? Continuing along this road here of a bunch of disease processes for you and breaking it down into as few terms as possible so that when you're studying, you're maximizing your time to identify keywords that ultimately lead you to identifying what disease process you're dealing with and how you should treat it and ultimately how to answer the question. And so now we're jumping into pneumothorax. The first thing you need to know is first, we're talking air in the pleural space. There's not supposed to be fluid or air in the pleural space. And so when it's air, you're going to find yourself dealing with the pneumothorax. Now, the second question and the second point on here is, how did the air get there? Is it an open pneumothorax? Is it a closed pneumothorax? Or is it a tension pneumothorax, which can be caused by both open or closed pneumothorax? Now, this springboards us into your talking points. When you're driving, when you're studying, you have to say open, closed. What does that mean? Well, open means that the air got into the pleural space via the parietal pleura. Okay, so you got to know your anatomy here. You got your parietal pleura on the outside. The inside covering the lungs is the visceral pleura. And an open pneumothorax is when air enters in to the pleural space through the parietal pleura. Now, what if it's closed? Closed would be when air enters into the parietal pleura, into the pleural space via the visceral pleura. So what's the difference? Well, parietal pleura obviously has to, and most commonly is associated with things such as chest trauma. So something has caused an open area or a laceration or something to the external wall that has punctured the parietal pleura and air has come in. A visceral pneumothorax or a closed pneumothorax is usually more common with barotrauma, to where the air is entering into the pleural space via the visceral pleura. And that is a closed pneumothorax. Now, if either of these create a check-like valve to where the valve opens when air comes in but then closes as pressure increases, and the air will on every breath increase in the pleural space, then eventually it will lead to a tension pneumothorax. A tension pneumothorax will ultimately push the trachea to the opposite side and increase pressure around the heart, and will show itself by a decrease in blood pressure. So if you ever have a patient that presents with signs of a pneumothorax and their blood pressure is low, then you need to treat it as a tension pneumothorax, and you need to relieve that pressure very, very soon, which we're going to talk about here in just a second. The next term I want to talk about is this term called iatrogenic. And iatrogenic is a term that means that this pneumothorax resulted from a medical procedure, meaning we caused it. Okay, so a patient that's in a car wreck, gets thrown from the car, hits a tree, and has a pneumothorax, that's not an iatrogenic pneumothorax, okay? But a patient who has either via mechanical ventilation and peak inspiratory pressures are allowed to climb so high that they cause barotrauma, that's caused by a medical procedure. A central line placement is one that your TMC loves to use. They love to talk about central line placement and post-central line placement. You have these findings that make you think pneumothorax. And that also is deemed an iatrogenic pneumothorax. Now, the next thing on here is when you're looking at your chest x-ray, what are you going to see to define and to lead you to thinking a pneumothorax? Well, the answer to that is increased areas of radial lucency, usually unilateral. So unless the patient has a bilateral pneumothorax, then we're talking unilateral, and you're going to see the loss of lung markings, which is going to lead to an increased area of radial lucency or an increased area of blackness. Okay? Now, the fifth point that you should probably keep in mind and be able to recognize and understand when we're talking about pneumothorax is subcutaneous emphysema. That's a dead giveaway that your patient has a pneumothorax. Okay? There's not another disease process out there that is associated with subcutaneous emphysema. Okay? So when you see that, then understand that you're talking about a pneumothorax. Unless you're talking about a trach dislodgement, that could also lead to sub-Q. But for the most part, unless it's not related to dislodgement of a trach, then you're talking pneumothorax associated with subcutaneous emphysema. And then the last thing is how do we treat it? You got to understand that you have to treat it by getting the air out of the pleural space. How do we do that? One of two things. Needle decompression, which is always going to be the answer when you're talking about a tension pneumothorax. The other option is to put in a chest tube to evacuate the air. And there you have it, guys. Pneumothorax. It's air in the pleural space. It can be open, closed, and both of those can lead to a tension pneumothorax. It can be caused by lots of different things. Your boards like to make sure that you understand and are able to find and recognize iatrogenic pneumothoraxes, which is caused by a medical procedure. Increased radiolucency is your key chest x-ray finding in a unilateral region wherever the injury happens. So if you're putting in a subclavian line on the right, then you'll see right apical increased radiolucency, meaning a pneumothorax caused by an iatrogenic procedure. And then 5 is subcutaneous, which is the key finding associated with pneumothorax. And then how do you treat it? Needle decompress or put in a chest tube. If it's a tension, then your answer is always needle decompress. Don't waste time. Get the air out. Okay? Hope this helps. Comments are always appreciated. Subscribe if you haven't already. Would love to hear your thoughts. Would love to provide more content for you during your commute or your study time. And I'm just here to help. So tell me what you want. Tell me what you want to see. I'll do it for you. Have a great day.